On and start recording?
Yes, I'll do that right now.
Hello, everyone. Thank you for joining us for today's webinar on a strengths-based approach to screening families for health-related social needs in the healthcare setting. My name is Shadi Hushiar. I'm a senior associate with the Center for the Study of Social Policy. Within the healthcare field, and especially in pediatrics, there's a great interest around refining screening approaches to detect health-related social needs or social determinants of health. In the emerging field of health-related social needs screening practices, several principles have been proposed to prevent a range of unintended consequences. The focus of today's webinar is on one of these principles, honoring the strengths of families by offering recommendations on how to operationalize a strengths-based approach to health-related social needs screening in the healthcare system. CSSP is delighted to partner with MLPB and Dr. Renee Boynton-Jarrett to bring you these recommendations, informed by a commitment to the Strengthening Families approach developed by CSSP and the 5 protective factors that serve as its foundation. We believe this work is important and a timely contribution to the ongoing discussions in the field of pediatrics around how to screen for social determinants of health in a way that is ethical, effective, and family-centered. Along with today's webinar, we have available on CSSP's website a companion brief. Before we begin, I'd like to take a few minutes to introduce our speakers. Dr. Renee Boynton-Jarrett is a pediatrician at Boston Medical Center, a social epidemiologist, and the founding director of the Vital Village Community Engagement Network. Through the Vital Village Network, she's supporting the development of community-based strategies to promote child well-being in 3 Boston neighborhoods. She joined the faculty at Boston University School of Medicine in 2007 and is currently an associate professor of pediatrics. She's nationally recognized for her expertise in the role of early life adversities as life course social determinants of health. Johanna Flax is the legal director at MLPB, among other things serving as a liaison to all of MLPB's private bar partners. Before joining MLPB in 2006, Johanna was in private practice and provided pro bono services to the Cape Cod Anti-Discrimination Task Force in its campaign to establish the Barnstable County Human Rights Commission. Prior to that, she served as Assistant General Counsel for the Boston Public Health Commission. Dr. Baraka Floyd is a pediatrician at Stanford School of Medicine and co-medical director of the Peninsula Family Advocacy Center, Stanford's medical legal partnership. In her time practicing at Gardner-Packard Children's Health Center, a federally qualified health center partnering with Stanford Division of General Pediatrics, she has successfully implemented several initiatives, including a postpartum depression screening and referral, pediatrician-driven universal social determinant screening and referral, and a diaper distribution program. And Rita Fernandez has spent over a decade working as a family partner in the Boston area supporting Cape Verdean and Muslim populations. Her passion for supporting the families in her community and providing quality care through advocacy extends across the lifespan. She is a certified doula, having trained with the Birth Sisters program at Boston Medical Center, and she is a certified mediator, having completed training through the Social Justice Mediation Institute. So I'll now turn it over to Johanna to begin our discussion.
Good afternoon, everyone. It is a great pleasure to be offering a reprise of a webinar that we presented in June, and to be able to do so with the benefit of a companion brief that will detail a great deal of the information we're presenting today. So I just want to give you the comfort that these topics we're discussing are intense and they're many layered, and we have provided additional explanation and material in the brief. So please do make sure to bear that in mind. I also want to say that it's particularly meaningful to me to be giving this webinar on this subject matter in the wake of toxic remarks that have been made by national leadership. And I say this not to be inflammatory, but to acknowledge the fact of the climate in which many of the families that we are all serving are attempting to be well. And it presents a challenge of a kind that we're here to talk about today. And more positively, we're offering this in the context of the Dr. Martin Luther King Jr. holiday week. So that is motivating, and with that, let me share with you what it is that makes a program rooted in legal rights and resources interested in social needs screening in the healthcare setting. So medical legal partnership is a model that teams, lawyers and healthcare professionals together to address health-related social needs. MLPB in particular works with healthcare and human services teams aiming to equip those workforces to be as effective as they can be as lay advocates to address upstream the kinds of social need problems that affect health and well-being negatively when they're not addressed. And our experience over the course of over 25 years of doing this work is that the healthcare team is eager for this. Next slide, please.
Hi, I just wanted to let you know I'm here. Sorry.
Good afternoon, Rita. Thank you for joining us. Good afternoon.
My apologies.
I just want to begin by talking a bit about workforce development. So 4 in 5 physicians surveyed say that unmet social needs are directly leading to worse health outcomes. So overwhelmingly, there is an acknowledgement among healthcare providers that unmet social needs are a direct culprit in terms of worsening health and lack of quality health promotion. Again, alarmingly, over 4 in 5 physicians surveyed say that patient social needs are important to address as their medical conditions, especially among physicians that are practicing in lower income and urban communities. At the same point in time, physicians often feel that they have inadequate resources to best address those needs.
Additionally, most physicians wished that the healthcare system would cover the cost associated with taking their patients from the clinic to the resources that are available to meet their social needs if a physician deems it important for their overall health. Next slide, please.
Welcome, Rita, by the way. For those of you who may have been on this webinar in June, we have the great benefit of a community health worker joining us to offer her perspective as a color commentator throughout this presentation. And we are so grateful that despite the difficult weather in Boston and the impacts that it's had on public transportation, you have been able to participate. So thank you so much, Rita.
Thank you. Thank you for having me.
I have an observation that is meaningful to me in this work, and as we get to learn later on in the presentation who has joined us for this webinar and from what disciplines, it's useful to note that public health and civil rights practitioners in many respects are attempting to address the same problems, particularly when focused on issues of discrimination and health inequities. The cultures of law and health are very different, though. So the culture of law tends to be focused on individuals, and that remains the case even though there have been some developments, some that have made some media noise in recent history around addressing disparate impacts, is the term of art, broad scale impacts that are caused by systems and are not necessarily intentional or the intent of individuals. That being said, in the world of civil rights, proving individual intent to discriminate remains the principal lens through which we look at issues of discrimination. It looks to find individuals at fault and to blame them. And if that sounds like an awkward lens through which to address issues, it is. it is difficult, and it's very hard to do because it's very hard to get inside people's minds. What I observe having the privilege of working with people in healthcare and public health is that what people are judgmental of is the impact. They're judgmental of the ill consequences of conditions that are bad for people's health and well-being. And public health looks to find those conditions that can prevent altogether in a primary or primordial sense, as well as alleviate symptoms that arise from injustice and inequity. And this presents an opportunity for us to work together on screening effectively for those conditions, and doing so in a way that makes sure we have the maximum resources, the full breadth of resources that are available to address those problems that cause inequities. Next slide, please, for Baraka.
As we think about the conditions in which people live, work, and grow that really give rise to health-related social needs, often it's easy to think about things in a negative frame, right? What things place our clients and patients and families at risk for poor outcomes? So it's really easy to say there's the presence or absence of a risk factor, as Johanna was saying, but in reality, this really isn't what happens. These risk factors are balanced by mediating variables or assets, and those really create the frame for the environment in which our families live, work, and grow. So it's important as we think about health-related social needs or social determinants of health that we take into account the assets or mediating variables that families have at play. And this is why it's not really possible to say that there's one best screening tool to really frame social determinants of health for families, and why it's important to take into account both risk factors and mediating variables when we're considering health-related social needs for families. Next slide.
So this graphic is an illustration really of what Baraka has explained so well, which is that in the center we have social determinants of health, which are in many buckets. And what we also have are some legal rights that are related to them. And this is giving you a little bit of a forecast around our focus, but you can see that there are, for every issue that, when the need is unmet, leads to a poor health outcome, there is some sort of resource available through public policy that often can be secured for people with the accurate legal information in the hands of lay advocates who are working with them. And so just to call out one or two, safe, affordable housing is the subject of a number of legal rights that people have, for example, to stable utility service, or to not being evicted without a specific process. And there are pathways to immigration status for some people. There are benefits related to food. There are benefits related to disability insurance. But if people don't know about these benefits, then they are not able to access them, to state the obvious. And so that's a big part of what we try to do in our work, working with.
And I know one of them, sorry for the interruption, but one of the things that I'm constantly bump heads with when I'm working in my community are, yes, there's a lot of resources out there, but a lot of these families don't have the access to these resources. A lot of these families are worried about more of their financial stability than their health. They're worried more about getting to work on time than getting to their appointments on time. I just feel like just to working with all types of families in different cultures, that the worries that of homelessness and unemployment rising so much it's hard to focus on their health or trying to get reasonable health care when they're constantly worrying about, will they be able to pay rent next month, or can they pay for the heat bill, or their gas bill. So there's a lot of things that come first in these families in terms of prioritizing the living needs more than the health the health needs.
Rita, thank you so much. That is not an interruption. That is actually precisely what I hope you will do, because you have brought home exactly the point that if we could have the next slide, we want to address. Next slide, please. So as Rita was saying, in her work on the front lines as a community health worker with individuals who could benefit from access to these health promoting resources, people are worried about what it will mean to show up in clinic if they're going to be missing time from work, as just one example that Rita gave. And so part of our work today in addressing this material is talking about how can healthcare practitioners, human services practitioners, and legal advocates work together successfully. We can do so when we don't miss opportunities to do screening encounters before people are in crisis. We can do so when we make sure that the way we're talking about these issues inclines families to feel comfortable seeking resources and participating in advocacy, and doing so in a way that even unintentionally does not alienate families. And it's frontline community health worker staff and other members of the health and human services workforce who lead on this and can be our teachers. So Rita, I invite you to comment as you have throughout this presentation. Next slide, please.
I know one of the things that I did get help some of these families to participate and wanting to want more in terms of working on all the important topics that you mentioned, especially the health needs. But just starting off bring a conversation. So what has worked for you? What some of the things you've done that's helped your living situation, and what some of the things that you want some extra support with. I think by starting the conversation and having the families lead and what's working and what's not, it helps them be more involved instead of us bringing the answers or showing them this is a better way to do it. Having them just share their experience more on what worked and what hasn't worked, and just start off there. I think that helped a lot in my case.
Thank you, Rita.
To briefly outline the goals of our webinar today, we have 3 simple goals. The first is to introduce you all to a newly published CSSP brief on this subject. It's called A Strengths-Based Approach to Screening Families for Health-Related Social Needs. The goals of that brief are really to build upon recent scholarship and strategies that help us avoid some of the unintended negative consequences of screening for health-related social needs. We present 6 recommendations to operationalize a strengths-based approach for screening. And we're excited about this because there's a real window of opportunity to link what we know using the Strengthening Families framework and the 5 protective factors that serve as its foundation, to link the known benefits of promoting family resilience and with evidence-informed screening tools, as well as a systematic process for incorporating a strengths-based approach to screening in healthcare serving organizations and in partnerships with community organizations. During our webinar today, we're gonna pull out some key examples that are especially pertinent in the current time around immigration status as well as racism to help us further make these recommendations more concrete and actualized. Next slide, please.
So now we'd like you all to participate in a couple of polls so that we can learn a little bit more about our audience. So which setting do you work in?
Hello?
Yes, so you can just select one of the following on your screen.
Oh, I'm not able to. I don't have access to the screen.
That's okay.
Okay, just for whoever does have, who is participating by screen, if you're able to vote. And if anyone is having technical difficulties with this, if you could just shoot a quick message in the chat box, that would be helpful. Because right now, we as organizers aren't able to see any responses. Kira, are you seeing any responses?
Yes, I am.
Okay. Well, why don't we close the poll just to and to know if you could share with us. That's great.
Perfect. Okay, so we have
I'm trying.
That's okay. We have healthcare and nonprofits and social services are our top participants today. Let's go to our next question. And in your day-to-day work, do you or your colleagues regularly screen for social determinants of health? Our options are yes, no, or somewhat. And we'll leave the polls up for about 15 seconds. Okay, so almost half do some screening and 30% do somewhat. And then we'll move on to the next. If yes, in your experience, how well are screenings for social determinants of health done? Very poorly, poorly, adequately, well, or very well? Okay, so about 50% of people feel adequately, and about a quarter of our participants feel they're done poorly. Thanks for participating. That's really helpful. Next slide, please. So just a quick overview of Strengthening Families. Strengthening Families is a research-informed approach that's focused on supporting families and children. And at the foundation of Strengthening Families is building the 5 protective factors of resilience and social connections, knowledge of parenting and child development, concrete support in times of need, and social and emotional competence of children. By building these protective factors, Strengthening Families really hopes to help families and children thrive by boosting their strengths, enhancing child development, and then diminishing the likelihood of child abuse and neglect. Next slide.
When we think about resilience, we really like to try to define it as good mental and physical health, despite the sales of early adversity. So when we think about resilience, we really think about 3 fundamental components of resilience. It's the ability to withstand, to adapt to, or to recover from adversities. And when it it helps make sense that resilience operates on many levels. So there's a person, an individual person's resilience, but there's also the resilience within the family. And one of the core components of the Strengthening Families framework is parental resilience. It's the ability for parents to manage stress and function well despite and when faced with adversities. And that can really serve as a buffer between the child and the adversities that are experiencing. We also think about strategies to mobilize resilience at a community level. What are opportunity structures? What are characteristics of the social and physical environment that really enable every child to achieve their full potential, to be as productive as well, and experience a full portion of well-being. And we believe that building resilience really offers the best opportunity to really improve health and ongoing well-being for individuals, but also for our society as a whole. Next slide, please. Very much in the same way, we think about social connections operating on a multitude of levels. So attachment and bonding between a parent and a child is really these strong positive relationships are really create the social experiences that are fundamental to our brain development, are fundamental to the ability to acquire and learn new skills, and are critically important, particularly in early childhood, during the largest period of brain development and the fundamental foundational work of developing relations. We think about social connections on a variety of levels as well. So there are all sorts of different forms of social support, emotional support, instrumental support, the ability to gain concrete support in times of need. And so for families, having a broad network of social connections that can provide different types of supports can also often enable caregivers to best attend to the needs of children, which is critical for their development. Within a community, having a community full of trusting neighbors helps to enhance the capacity for greater social connections. Next slide.
When we think about knowledge of parenting and child development, we think about allowing a parent to really understand what to expect for their child's physical development, for their cognitive development or learning, for their language, and then for their social and emotional development. When a parent knows what to expect, this really can help set them up for success. So when they can anticipate things like landmarks for temper tantrums, then they're prepared when they happen. Speaking to things like parenting, this increases the understanding of the importance of what is necessary for a parent to be able to set their child up for successful development. They can create an environment for their child to learn through play, for their child to learn through trial and error. They can learn how to provide predictable routines and to provide nurturing and responsive relationships. They also can be able to understand cultural and structural factors that can influence how they parent and can also influence how they view their child. Additionally, understanding child development can help them know when their child's development may be abnormal and when they should seek help. Next slide, please. This really speaks to what Rita brought up. When families don't have concrete supports in times of need, they may not have things like their basic needs. So the things that families need for everyone in their family to grow. So this extends for things like basic needs like food and utilities, stable and safe housing, and financial stability. So in an ideal world, a family would have those things so that then they're able to seek out things like medical services or mental health services or educational supports or legal services. And I think Rita hit the nail on the head. When a family doesn't have basic concrete supports, they're not able to then seek out those additional supports that they're entitled to allow that family to really thrive. Next slide, please.
The final component of the Strengthening Families framework is the social and emotional competence of children. So what do we really mean by this? Well, in order for children to really learn and master their environment and gain new skills, the ability to regulate your emotions and to have a strong foundation of social emotional regulation becomes a critical factor in the ability to learn new concepts, build strong relationships, and acquire new skills. The social and emotional competence of children is a central factor in the ability in life chances in the future, as well as emotional health and well-being for children. So the community of caregivers and providers and the environmental, social environment and social ecology that children grow in becomes a critical factor in supporting the best and most positive social and emotional development for children. So it's a real critical factor in the framework. Next slide, please. We know when we look at the general population of families in the United States, the prevalence of health-related social needs is very high. Over 43% of children under the age of 18 live in low-income families or households with income levels 200% below of the federal poverty line. Over 60% of Native American, African American, and Latino children live in low-income families, as compared with 30% of Caucasian children. Over 30% of Native American, African American, and Latino children live in families with income below the federal poverty level, compared to 12% of Caucasian children. So when we think about our process of achieving health equity for all children in society and all families, we really have to look at the disproportionate prevalence of health-related social needs among racial and ethnic minority children and families, as well as among families of lower socioeconomic status. When we're thinking about safe and stable housing, the opportunity to have nutritious and adequate, secure food, economic stability of neighborhoods, job opportunities, quality education, quality transportation systems, and an enriched social environment with opportunities for recreation, safe play, and exploration. So we know that your zip code and the geography that you live within also really determine social mobility and life chances and opportunities for health as well. So health-related social needs really extend beyond the family. So a lot of what we're talking about today in this webinar is really building our competence to identify structural factors that can be affecting the health and well-being of families. Next slide, please.
So we have 6 recommendations, and I think recommendation is a very important word choice, because among the acknowledgments that we owe you as participants is that we are not offering you a template screen. So for those of you, and Baraka had mentioned this, for those of you who are very reasonably interested in knowing, so where is that screen that is strengths-based and addresses all of the health-related social needs that people may have concerns about? It doesn't exist. And our opinion is that it's not viable for such a tool to ever exist, because it cannot possibly appropriately address the diversity of need in the many different communities where you are doing your work. So we have recommendations that we think can inform and enhance your screening practice as it already exists, or as you in a variety of different settings may be called upon to administer particular kinds of screens, or importantly, develop different kinds of screens. So the 6 recommendations we have in brief are, if you're wondering whether a screen that you are contemplating is going to resonate with a certain community, this may sound like stating the obvious, but ask that community. Make sure to include members of the community that you aim to serve in actually developing the screen, identifying priorities for the subject matter of screens, and informing you as experts about how to administer the screen. Make sure to screen for protective factors, not just risk factors. So we have spent a lot of time talking about risk factors, but when you're familiar with the protective factor framework, you can include that and get a more accurate sense of what the problem is to be solved, calling upon all the strengths that families can bring to bear. Do feel empowered to set priorities that are family-centered, that are informed by the communities you're serving. We are here as a community that's worked on different parts of this issue to validate that practitioners are called upon to ask any number of questions, and the list just gets bigger and bigger, and the time to ask them gets smaller and smaller. So there's got to be some triage done, and so we have a recommendation about one way to do that. The workforce administering the screen has to be trained in trauma-informed practice and strengths-based approaches, or they can't be expected to perform in a trauma-informed and strengths-based way. So again, it may seem like stating the obvious, but it is a specific concrete, it's a specific concrete quality that you can include in your development of a screen or a screening practice. It's crucial to recognize that asking people about unmet needs is not risk-free. And it's also crucial to acknowledge that the risk that people experience and the strengths that they can bring to bear to avert that risk are not happening in a vacuum. They're happening in a broader societal context. And if we don't acknowledge that, we undermine our work and people's well-being. So we're going to address each of those recommendations in turn. Next slide, please. So, Renee, are you available to comment on this particular recommendation?
Yes. So involving families and communities in the development and administration protocols is critical. Families should be considered to be experts and included as such in the development of any screening tool that will be used among a population or community of families. Their wisdom and insight can be invaluable. There are well-known community-based participatory research methods that can be utilized for facilitating discussions and gathering feedback, iterating and improving screening tools. But caregivers should be consulted as experts, not just about the tool itself, but about the process and format for administering the tool, as well as the protocol itself prior to finalization. Next slide, please. It's also important to screen for both risk factors and protective factors. Effective screening processes really need a balance of the both. So when we're thinking about screening for risk, screening for protective factors becomes an opportunity for a family to develop, to demonstrate strengths that already exist within the family unit, within their community, and within their social network scale. This becomes an essential part of helping to develop and build strategies. As providers, we're often concerned about opening Pandora's box or the empty toolbox. By screening for protective factors as well, and strengths as well as risk factors, we do not have to fear the empty toolbox as much, because families in themselves will identify and map their resource network or their strengths, and that can be a great place from which to build upon and begin to identify and address some of the challenges. It's also a part of the process of helping to identify a broader set of community institutions and resources that can be brought to bear to help address health-related social needs. Next slide, please.
So in what ways can you set priorities so that you can do a more rich screening intervention, an intervention that is going to engage people in identifying needs they have, strengths they have that can be brought to bear to meet those needs, and that does so on a time frame where it's not already a crisis, where this sort of interaction is happening preventively. In order to do that, it's important to home in on a particular set of priorities that are informed by the populations you serve. And Rita has already shared from the perspective of serving communities in the Boston area that adequate housing, the capacity to keep your job without having penalties for missing time from work, having adequate income to make sure there's enough food on the table and that lights and heat are on, are priorities that people have, and when they're not met, they already are going to be behind the 8 ball when it comes to addressing and making health needs a priority. And so those observations align with a set of priorities that we recommend, which are focusing on concrete supports in times of need, and specifically food and housing security. And that aligns as well with health-related social needs as defined, a subset of health-related social needs as defined by Centers for Medicare and Medicaid Services. If we home in on those priorities, we're going to prevent what we call in a light way checklist checkout. And I think that's something that may resonate for people as individuals who are often polled about things in your own healthcare appointments. When people read you a laundry list that might as well be the kind of fine print about side effects that are put into the visuals of television advertising for pharmaceuticals, you check out, right? You know, people might say, you know, are you lightheaded? Are you short of breath? Have you been regular? Though all these questions, you just say, you know, no, I'm fine, because that is an overwhelming list. So that is something that can be averted if you choose some priorities. Now, let's acknowledge that in the communities where you are working, a priority may come to mind that's different than what we've recommended in terms of focusing on housing and food security. And that's okay. It may vary during time of year. In climates like here in New England, it makes sense sometimes to prioritize around the fall a focus on utility service and assuring that people don't lose the utility service at a time where, according to some public policies, it's harder to secure again. And so that's something that can be informed, obviously, by the experiences where you work. But you do want to choose something that is actionable and that allows you then to ask people what they've done in the past, for example, to manage the cost of utility bills as they begin to mount in the fall. And that's a strengths-based approach that's different than just saying, are you worried about your utilities being shut off? To be able to say to people, this is a tough time of year for everyone. And so we ask everyone, what did you do last year to make sure that you were able to maintain utility service? What were the strategies you used? Then you get to learn whether people do have a strategy to bring to bear, but a particular concern about this year, and people may be more inclined to engage with you. So in the brief, we offer some additional examples of this kind, but the key takeaway I want to offer to you now is that when you choose priorities where there are some remedies available to bring to bear through the existing legal and public policy context, that is helpful, as Renee said, in terms of addressing concerns about having an empty toolbox. And B, you're able to be universal in the way that you screen your population so that no one's feeling targeted or presumed to have a need that they may not have or that may not be a priority for them, and able to learn what strengths they have to address the problem. Next slide, please.
So next is to assure that your workforce is trained to administer in trauma-informed and strengths-based approaches. So I'll just briefly review a couple of the strategies listed in the brief. So first, for team-based care, it's really important that you use a universal precautions approach such that all team members are trained in trauma-informed practices with every single patient, because it's really impossible to know each individual patient or family's history of trauma. And the other part, Johanna already kind of went over this, but really performing universal screening for health-related social needs. And by doing this, you reduce the likelihood of stigmatizing or alienating or even confusing families. If a family was screened when they came in on Tuesday with one child, and then they're not screened when they come in on Thursday, that can be confusing. Another thing that's important is incorporating cultural competency, structural competency, and implicit bias mitigation approaches into care. This is really important because it can bring to light or highlight possibly alienating lines or styles of delivering questions or asking questions, or ways that you can really engage patients in a way that's more comfortable for them. And then the thing to keep in mind is the fact that this is a continuous learning process, because we all have things that we can continue to learn over time as we come into contact with different people in our practices. And then I think the other two things to take into account is avoiding stigmatizing those with literacy and language barriers. One of the things that can be done is not requiring those that are being screened to take that extra step to tell the screener or to mark on a survey that they're illiterate or have low health literacy, and really having a high index of suspicion and being extra observant for those who may need extra help, rather than asking them to take an affirmative step to let us know that. Next slide, please.
Also would like to mention that a lot of the families that I also work with deal with about 35% of the families that I've been working experience in the last about 8 years. A lot of the families are dealing with secondary trauma, which is something that I found to be ignored, in the Boston community. Mm-hmm. Secondary trauma in terms of, witnessing street violence, witness domestic violence, witnessing police brutality, witnessing even in the school system, in terms of the parents being treated, what's another word I could use? Not treated equally with the language barrier and the resources that are provided to the families that English being the first language and families with English being the second language or not be able to speak English at all. I know. I think that secondary trauma also needs to be addressed, and it's really being ignored in our community.
Rita, this is
Thank
Johanna.
you so
Are
much,
you?
Rita. That really actually drives perfectly into our next point around health-related screening, health-related social needs screening as being not risk-free for families. So when providers and medical teams can understand the prevalence of trauma and histories of trauma, whether it's historical trauma, community trauma, trauma within families or interpersonal, as well as the impact that that may have on, on future engagement with institutions of care, with healthcare professionals, and with governmental agencies such as the Department of Children and Families. It is very important to then realize why a social risk screening does not feel risk-free for many families, particularly families that don't have access to legal advocacy supports or a full disclosure of their legal rights. So caregivers may worry that by acknowledging their basic needs, they may be opening the door to being accused of harming or failing to protect or failing to adequately support their child or family member. This is critically important to understand so that one, providers can contextualize their place in the system, but also really understand the foundations of therapeutic alliance and trusting relationships that are important. Caregivers may be concerned that they may be judged or blamed if they disclose particular social needs. So a provider's ability to acknowledge larger forms of structural violence, as you've mentioned, Rita, such as police brutality, such as residential segregation, such as unequal access to education or employment. It is very validating for families because it contextualizes their experience and the conditions their family may be facing, and contextualizes their current and past social needs in a much broader context than their own set of responsibilities as parents or caregivers. So if we could go to the next slide, please. I think I've kind of covered both of these points. One, health-related screening is not risk-free for families, but also that by explicitly acknowledging the broader social context, it is something that a provider can offer. There is now indisputable medical and public health research creating and establishing a strong and consistent association between social factors, neighborhood environments, and morbidity and mortality. So we know that racism has a direct impact on health, but we often won't discuss that in the context of a conversation with families experiencing profound health-related social needs. So it's very important to begin to acknowledge this knowledge and information we have, and use it for developing professional competencies. Next slide, please.
So building upon Renee's introduction to a meaty part of this webinar, which is how to do strengths-based screening that also acknowledges risks that are, to just say it plain, not the family's fault. How to acknowledge this in the context of a screening encounter, in the context of providing routine health or human services care. How to do that in a way that is effective and that is feasible and that is in keeping with the reality of the lives people are leading and where they're leading them. It is helpful, I think, to offer by way of a more interactive process some examples of the structures that are created by law and public policy that impact the lives that people are living and trying to live with security around things as basic as food and housing. So quickly, if you've had a chance to peek at this, multiple choice question, we're talking about Boston simply because that's the context in which I'm doing my work. Let's give people another 10 seconds to say what they think is true among these statements, that racial segregation in Boston actually was the result of intentional public and private concerted action, that zip code is predicting long-term health better than genetic code at this point, that there's still a high prevalence of straight up discrimination against Black and Latino people in the rental market, and that the disproportionate rate of incarceration of Black men and eviction rates of Black women with children perpetuate economic inequity in American cities. And that it is still the case that Black women are significantly more likely than white women to give birth preterm, even accounting for a variety of socioeconomic factors apart from race and behavioral factors. Let's close the poll and just see what people think so far. So I think we may be having a technical difficulty with the poll, which is okay. I'm just, oh, actually, it's interesting to see that that most of you are aware that the answer to that is all of the above, and that may be a reason why you are on and have self-selected to be on this webinar. A question that arises from that is how, and this is really important, how do we square wanting to honor all of the strengths that people have at their disposal to bring to bear to address unmet needs with structures that have really undermined them, that that people are swimming against a pretty strong tide when you think about this sort of a background. And so I want to just say that this is, while there is, maybe you would experience a competing goal of wanting to empower people and focus on strengths, but at the same time address risks that are created not by individual conduct, but by the structures in which people live. I would say it's not a competing state of affairs. It's actually a complementary way of looking at the problem. And so it is crucial to take opportunities when someone is trying to address the need to find affordable housing and are running up against real hardship, to be able to acknowledge that there is a long history here that creates a backdrop and that creates a strong tide that's hard to swim against. And it's not your fault, and you're not being judged as a parent for having a difficult time finding an apartment that you can afford in Boston and where you won't be turned away simply because of the name that appears on your application. So let's move through, actually, if we could, because it's, I think, really crucial to save some time for question and answers. Let's just move through to slide number 34, because there's a lot of true false, but if we're having some technical difficulties, I'd like to just make sure that we save time. So slide 34 for Baraka.
Okay. So due to increasing threats of stricter immigration enforcement and restrictive immigration policy, every piece of information shared, including those that we get for health-related social needs screening, requires a cost-benefit analysis for our families at every step. because if the wrong information gets into the wrong hands at the wrong time, families could be detected by authorities that have the power to incarcerate or deport them. This is really true for our mixed status families. So these immigrant parents with U.S. citizen children have daily stresses, and it makes the appropriate assessment of their risks and strengths even more important. The other things that we have to think about is past trauma from the country of origin in any immigrant family can contribute to skepticism and fear when we ask questions that don't seem to be directly related to their health care, which is understandable. And though our families appreciate health-related social needs screenings, many families are hesitant to answer truthfully. And sometimes they don't want to request further information or referrals that are for immigration-related needs or concerns. Next slide, please. So this makes it even more important to maintain the trust in our patient and provider relationship. So some of the best practices include affirmative transparency with patients, that any question that we ask about immigration status, they're only, back one slide. They're only in relation to their eligibility for services and resources to support their health-related social needs, and that we won't record them unless we have their permission. We also have to be vigilant to avoid references to immigration status in their medical records. And then practicing simple gestures like turning away from the computer or putting down our pen to show respect for their privacy. It's also really important to have materials available in multiple languages and at varying literacy levels, both orally and in writing. And then it's also important to have curated legal advocacy resources that are readily available at your site for families who need qualified immigration assistance that's affordable or free. Next slide, please. So now I'm going to go over a success story from our clinic that kind of puts into practice some strengths-based health-related social needs at screening in an immigrant family. So at our clinic, our health-related social needs screening is based on a community asset map that was designed with the final step verifying the legitimacy of our community agencies by local community members. Our in-person screening protocol was designed such that we don't ask questions that we can't address, and we don't send families to agencies that don't have good local standing with the communities that they serve. So we came back and asked our families about these community agencies and said, would you go there? What's the reputation of this community agency in your community? So this family came in with their child for a newborn well child check and did a health-related social needs screening per clinic protocol in person with the pediatrician. And they were screened for food insecurity, housing insecurity, financial insecurity, and intimate partner violence and child care concerns. And then we also screened for family support and per clinic screening protocol and community supports like home visitors and family and peer support. The family said that they had food insecurity and they had a large family and lots of supportive neighbors that they knew well. And they also had a large faith community that they were close to. The pediatrician offered information for WIC in response to their positive food insecurity screen. They also wanted to provide information for SNAP and local food banks, but the family declined that information. So the pediatrician didn't provide it in response to the family's desires. On the way out of the door, the family said, well, if we go to any of those places, will it put our family in danger? Not everyone in our house has papers. And this family shared that they were receiving meals from their neighbors in their faith community, and they thought this would be enough to hold them over for the time being. So at that point, we sat down and chatted together about a plan to hold them over for food. And we offered them a referral to our upstream legal team to discuss immigration concerns with accessing public benefits. Next slide, please. So at their return visit in 1 week, the family shared that accessing support for food for their U.S. citizen children would be okay for their family after they discussed with our legal team. And by that visit, the family requested information for all of the things that we discussed. So for SNAP, for WIC, and local food banks. By the 2-month visit, the family is now connected to WIC and SNAP, and they pick up produce once a week from their local food resource center. The mom was really happy with the support that she continues to receive from her faith community and from her neighbors as she plans to go back to work. So with this family, by identifying their strengths and their needs, our medical team was able to focus on the family's priority for their very real fear about their immigration status. And we were also able to make sure that our very real fear for that child's immediate need of being fed and the family's immediate need of being fed was met as well, because we couldn't let the family just walk out of the clinic without making sure that the baby wasn't fed, that the baby was fed. And we also were able to make sure that we built a foundation of trust with that family by providing the family with legal resources. So this was able to kind of demonstrate that by screening for strengths and not just screening for risks, we were able to do exactly what Renee and Rita were saying, being able to address the family's priorities. And then also by looking at the family's strengths, we weren't looking at this empty toolbox and saying, oh no, we don't know how to address this family's issue of immigration and they don't want the resources that we want to provide them for food. Next slide.
I want to just take an opportunity to ask Rita if you have any reflections hearing about Baraka's success story and about the particular stress that this immigrant family was experiencing, including language difference, to comment on the issue of secondary trauma that you mentioned, the trauma of witnessing harm, and whether you have any strategies from your work, Rita, to address that. You've identified it as a trauma that is unacknowledged, inadequately acknowledged, and I just wanted to create an opportunity for you to comment on how you think that members of the workforce like yourself and other members of the healthcare and human services and advocacy workforce could do better to address that in our screening practice. I think we may have lost Rita again, and I apologize for technical difficulties that we have had. I think I would just say that this is an opportunity from my humble perspective to add that a concrete strategy that feels important to me sometimes is to find a way to communicate that you're an ally, and that there are examples of ways to do that that people may be familiar with, that are as simple as, for example, in the context of being a safe space for LGBTQI individuals, having a rainbow flag as part of what is on your office door has meaning. It communicates your desire to be an ally, which is always a work in progress, but at least it communicates that desire. And how can we do that with immigrant families, for example? How can we do that for, to use a term that was coined by nurse and professor of law retired Vernelia Randall, descendants of Africans enslaved in the United States, pronounced deus. How do we communicate an intention to be an ally? And one way to do that goes back to earlier comments in this presentation about acknowledging awareness of historical trauma. So acknowledging simply the history that for an undocumented person from Mexico, let's say, who has experienced some alienating comments in the public sphere, particularly recently, acknowledging awareness of history that there wasn't always a border between present day Mexico and the United States, that border was imposed and people used to, who were here long before Europeans, used to be able to pass freely. Acknowledging that in the course of discussion can be useful. And is this just add water? No, it is not. Can you say, okay, I'm going to have a list of the history of everything that has been oppressive in this country and make sure to choose one to comment on. Of course not. This has to do with your relationship with individuals and building relationship, and there is a level of improvisation, but being open to and looking to acknowledge that can be very important and valuable for trust building. And I know that's something that that Rita and I have been able to discuss in our past work together. I'm going to share one more success story that happens when trust has been built and a strengths-based approach is deployed. And it has to do with a home visiting program, Healthy Families, which is specifically strengths-based. And greetings to Healthy Families leadership that I know may be participating today. A home visitor working with the parent of a premature infant who was living in the exurbs, meaning because it is so hard to find anywhere to afford closer to where you may receive health care in Boston, many people are living far, far away. And a pediatrician had prescribed a special formula for a child's unique nutritional growth needs, which, by the way, can run $40 a can. And I mean a can that is a serving of food. I don't mean a can that is a serving of a week's worth or more of food. The family had only 1 day of supply left. Now, can you imagine being the parent of a young child who has been identified as, quote, at risk already for being in this program, disclosing a fear of having only 1 day of food left? If you're going to disclose that, it means something has happened that is successful, that has built your trust and your willingness to be able to share that. The parent was told that the company was going out of business and that they couldn't supply it anymore, and that there was no way to provide immediate delivery at another supplier. The home visitor was able to contact a member of MLPB's team who manages the home visiting program, and that attorney was able to coach the home visitor on what particular kind of magic words needed to be said in communication with the health insurance company that would get them to expedite filling this prescription. And that worked. So the family was supplied with a new supply of this very expensive basic need the next day. And next slide, please. It was the strengths-based approach to screening this family. In the beginning, there's a lot of screening done in that program, and the approach that's brought to it is part of what builds that trust. So in closing, before we turn to some Q&A, next slide, please. So Renee, are you available to just give us a quick thumbnail highlight?
Absolutely. So thank you all for hanging in there with us during this important webinar. We're very excited to have some time to begin to launch into questions. Just to briefly review our 6 recommendations for strengths-based approaches to health-related social needs screening. The first is involving families and communities in the development of the screening tools and administration protocols. So really seeking the wisdom and expertise of families, caregivers, and community members for the design, the rollout, and the ongoing iterative improvement of the screening process within your setting. Next, screening for protective factors and not just risks. Even if you include a simple single question that elicits the ability for a family to define and share a strength and protective factor, that's a step in the right direction and something we can all immediately begin to do. You can't do it all, and you can't do it all at once. So begin to set priorities and set those priorities in a family-centered way so that, again, families are engaged in decision-making. Assure that the workforce that's responsible for administering the screening and every aspect of patient care is trained in trauma-informed, strengths-based approaches. That's the entire member of the staff, not just the providers, but the front desk staff, the folks who call people on the phone, the folks in billing, the folks who are responsible for a variety of aspects of the healthcare team should all understand trauma, understand the universal precautions approach, and strengths-based approaches. Own that health-related social needs screening is not risk-free for families. So acknowledging the importance of trust, transparency, and acknowledging how frightening or scary health-related social needs screening can feel and be for families based on past experiences and their current reality. Explicitly acknowledging individual risk in a broader societal context. Structural competency, really contextualizing the experience of families within a broader set of social forces is incredibly important, and we have indisputable medical evidence to show that those social forces influence health and health-related trajectory over the life course. Thanks. Next slide, please.
So this is our opportunity if there are any questions that have come in. Kira, do we have any questions that have been typed in?
Yes, we do. Would you like me to read them aloud?
I think that would be great. And why don't we take an order of how they were asked?
Okay.
If you also would rather just make the question visible.
I'm not sure if it's possible to make the question visible,
Okay.
but I'm here now.
Great.
So from Carrie Jasper, I'm so glad you are addressing the issue of race. So many try to avoid the inequities which stem as a result of race. How do we get this more a part of the discussion?
Thank you. Thank you for that. I would like to turn to my colleagues who are working in the field in medicine to share any of the ways that you feel like you've been able to get this on the agenda effectively. What has worked?
I would just say very briefly that I appreciate your comment and I appreciate your question. I think that's something we're continuing to work on. However, I think if we think about the professional obligation that we have as providers to understand determinants of health and well-being, we know racism is a determinant of health and well-being, and we have very strong medical and public health evidence to that effect. So we have a professional obligation as well as a moral obligation to talk about something that may feel very uncomfortable, and it may be hard to feel like you're the only one or the first one raising what can feel like an uncomfortable topic. There are many programs around implicit bias and helping providers to understand implicit bias that are being used at healthcare institutions, public health institutions, and other healthcare service organizations around the country. So I do think that's a good place that is just a starting place.
I agree. I think the implicit bias trainings that are utilized across the country are a good floor with which to start. The other place that has been helpful for me to start the conversation is with our residency trainees coming in and working with them on the ground in training when those issues come up in our clinical care.
Thank you, colleagues. I think I would just add that I don't know who gets credit for this particular meme, but the notion that everyone's entitled to their own opinion, but not to their own facts. And I think increasingly calling attention to the facts and their health impacts, as Renee was saying, is really the way. You may not be able to change people's minds about their comfort level talking about issues of justice and equity, which is how I was sort of framing it up at the beginning, that in the civil rights context, in the legal context, we speak a great deal about justice and equity. And in healthcare, we talk about, wow, people are sick. For example, a great number of babies are not making it to age 1 alive. What's about that? What are the common denominators? Oh, look, this is a much bigger problem for the babies born to African American women, to Deis women. Okay, now, how are we going to, if we care about babies and babies staying alive, then we need to care about what are some of the factors that are at play, and we then get to racism having an effect. And so to some degree, I think focusing on racism as opposed to race is a helpful, a structural racism. How is that impacting health is a valuable tool. And so we just have to get the facts out there and keep them on the table, even when it's uncomfortable. And I wish I had more on that, but we're plugging away again in this Martin Luther King Day week.
And sorry, Johanna, I think piggybacking off of that, I think looking through the lens of structural competence is another way in which to think that through.
Yeah.
As well.
Yeah. That's a very good term of art to be including. That has to do with knowing our history. Yeah. Is there another question? Because I think we do have time for another question.
Yes, there is. So from Elizabeth Hansen, can you comment on building a medical team that can address social determinants of health? I'm a pediatrician in a large multi-specialty clinic. Admin has not agreed to pay for health workers, extra nurses, etc. Any reimbursement tips that could help fund a team?
Wow, great question. So this is not my strong suit. So, but what I would say is documentation. So if there is a partner, a sister organization, similar in size, similar capacity, that is doing some of those things, has navigators, has a more enhanced social services department, doing a site visit with them, learning how they set up their funding structure, how they pay for those programs is always a great thing to do, rather than reinventing the wheel. And seeing if you can get a tiny bit of stimulus funding for a pilot, to be able to pilot with a small group of patients, or to be able to pilot for a short period of time, innovation that you think will lead to, one, better care and service for patients and families, as well as enhanced service delivery, and ultimately be cost saving. So, and then there's also volunteerism. So if there's volunteer services at your organization, and there are members of the community who are interested in helping to be a part of this model. Maybe through volunteer services, you may be able to end up with 1 or 2 patient navigators. So again, out of the box creative thinking, because often people are more than willing to civically engage to achieve better quality care and better service. So something to keep in mind.
Thank you for that, Renee. And thank you. Oh, do we have one additional comment on that?
Yeah, and then backing off of that, I think the other thing is starting small. Is you don't have to screen for everything, along with the idea of setting priorities. So thinking about screening for one social determinant and building from there often is a way to make the case with your organization.
I think that's so smart. And I'll just add one more, which is a controversial but often effective way to get your toe in the water, which is to pull the data on which individuals that you're serving are falling into a category known as being a high healthcare utilizer, because you mentioned cost as a driver, and most of us who are on this call are probably not here because it's dollars that motivate us. But when we're talking about a limited pot of money to meet a vast need for healthcare delivery, being able to identify, in terms of starting small, a particular population that perhaps because of unmet social needs is engaged in avoidable healthcare utilization. And then that might be a population to begin to show the impact that you can have, and with success in that way, and what you learn from that, you may be able to get investment from your system.
Great. Thank you, Johanna, and thank you to Renee and Baraka and Rita for joining us for this conversation. And thank you, everyone, for joining us for today's webinar. Please visit us on our website at cssp.org for the companion brief for this webinar. And feel free to reach out to our speakers or myself if you have any additional follow-up questions. Thanks so much.
Thank you, everyone.
Thank you.
Thank you.